Kia ora, K2. My name's Belinda Zaparinuk, and I'm going to be discussing removing panic from a pandemic. A system was devised by a group of medical professionals and medical organizations who came together to help manage the care of patients who were diagnosed with breast cancer or were going to be diagnosed with breast cancer. In every country of the world, breast cancer occurs in women at any age after puberty, but with increasing rates in later life. Breast cancer has now overtaken lung cancer as the world's most commonly diagnosed cancer and is responsible for 1 in 6 of all cancer deaths among women, according to the statistics released by the International Agency for Research on Cancer in December of 2020. Although we have made progress in reducing breast cancer mortality in many high-income countries during the last 2 decades, little progress has been made in low and middle-income countries per the World Health Organization, or WHO. Late-stage diagnosis and inadequate access to quality care contributes to a higher mortality in these lower-income countries. Together, we can address this unacceptable inequity. Breast screening is considered an elective or non-urgent procedure. Because the COVID-19 virus can be very contagious, many hospitals and breast center clinics canceled or even delayed care. Decisions were made so that we could conserve medical resources, including staff and personal protective equipment, also to limit exposure rates. During a pandemic requires thinking outside the box. A system had to be put in place. They had to base priority. Still deliver care, but limit exposure and to protect the patients and our healthcare workers. Priority A category. Priority A patients have a condition that is immediately life-threatening, clinically unstable, or completely intolerable, and for whom even a short delay would significantly alter the patient's prognosis. Assuming efficacious treatment, these patients are given top priority, even if resources become scarce, require urgent treatment for preservation of life, or control of progressing disease or symptomatic relief. Priority B category. These patients do not have an immediate life-threatening condition. Treatment or services can be delayed up to 12 weeks, but not indefinitely. Would not impact their overall outcome. Most breast cancer patients will fall under the priority B. Longer delays could impact outcomes in some priority B patients, and triage may become necessary to justify which patients should undergo treatment versus further delay. Patients within the priority B category will be substratified as B1, higher priority. These are your more aggressive breast cancers, your invasives, or your stage 4 or 5. Your next category would be 2, mid-level priority. These are patients that have been diagnosed with a breast cancer. Maybe it's in stage 1 or stage 2, and their surgery needs to be delayed. So, and they may not be getting their reconstructive surgery at that time. So those patients can fall into that category. And B3, that's the lower priority. Those are the patients that have early breast cancer, and they can have their surgery delayed and the radiation treatment postponed. And these will be defined by each breast cancer subspecialty. Priority C category. These patients are the patients for whom certain treatments or services can be indefinitely deferred until the pandemic is over without adversely impacting outcomes. This is where all of our screening and preventative care patients went into this category. Preventive care was disrupted by the COVID-19 pandemic. Screening exams fell by 58%, while diagnostic exams fell by 38%. 30% of patients reported they chose or considered changing or delaying their own treatment for fear of contracting COVID-19. There was a feeling of anxiety in 80% of the patients concerning their care affected by the COVID-19 pandemic. In 2019, for example, 63.9% of diagnosed patients presented with stage 1, that's the early breast cancer disease, compared to 51.3% in 2020. Conversely, 1.9% of patients were diagnosed with stage 4 breast cancer in 2019, compared to 6.2% in 2020. Those are your patients that have the later type of breast cancer. That's where we are seeing most of our category C patients who delayed their annual screening mammograms. Now they're falling into that later stage of diagnosis of breast cancer. So what have we learned? Don't delay your preventive or diagnostic care. It's really important to get those screening mammograms, or if you're having an issue, go see your doctor. There have been stricter safety practices implemented within your hospitals and your clinics. It's making it much more safer to visit. There's masking, physical distancing, telemed visits, and shorter hospital stays have been implemented. COVID testing before surgery and before any type of treatment such as radiation and chemo have been implemented. It also allowed the care providers to become more creative with their treatment plans. Use of neoadjuvant chemotherapy. They experimented with those category B patients, those patients that were in those subspecialties, those category B2s. Those were patients that were maybe diagnosed with not as an aggressive breast cancer, but needed to have their surgeries, but the surgery was delayed. Maybe they couldn't get their reconstructive surgery. So the use of neoadjuvant chemotherapies was implemented in keeping those cancers at bay. Also, the healthcare providers, they experimented with the use of accelerated radiation breast treatments and partial breast radiation treatments. A standard breast radiation treatment protocol can run anywhere from 6 to 8 weeks every day. So some patients were, couldn't meet that criteria because of the limitations of being allowed into the clinics. So the patients were giving either an accelerated treatment plan with over 5 weeks, or it was a partial breast radiation treatment plan. Maybe they just treated that area of concern in 1 week and the patient came in 1 to 2 days. We also became better prepared. We had a better understanding of the supply chain, making sure that we had our personal protective gear, we stayed stocked on our masks, our wipes, everything to take care of the patient better. It also allowed us to become more efficient and improve the patient care, because with the limited amount of visitors that came in and out of the hospital, we could focus just on that patient. Telemed, it increased by 58% and virtual appointments by 45%. And that also we shortened hospital stays, which became a more positive change for overcrowding and became better cost effectiveness, use of our supplies. But the big question, and it still remains to be seen, how these spikes in the COVID-19 cases might affect breast cancer treatment and screening going forward. We've already seen that we have documented proof that the patients who delayed their annual screening mammograms are now being diagnosed with more invasive breast cancers. Some experts are stating that we may see this trend up for the next 10 years. Diana Kotu, thank you. Thank you for inviting me to speak at your conference, and thank you for taking the time to listen to my lecture. Please remember to have your annual screening mammogram in accordance to your country's guidelines, continue to have your clinical breast exams, and practice breast self-awareness. Thank you so much and have a fabulous day.